left ear, and this wax is impacted halfway beyond the ear canal, so we call that area the medial part of the ear canal. If it was more near the entrance, we coined that more lateral. And I can just about insert the standard Zollner suction probe through this narrowing, and I'm just slowly but surely bringing this wax forwards. It is a bit soft. They have been using a bit of drops. Sometimes patients can overuse earwax drops and it turns the wax very mushy. And when you've got mushy earwax, it clogs up the suction probe, and you have to constantly remove the suction probe from the ear. And there is a cleaning rod, a sterile cleaning rod that comes with each suction probe that we use. So we just insert the cleaning rod up the suction probe to unblock any blockages due to earwax. And sometimes when it's mushy and a bit wet, it stains the ear canal a lot. So although you remove the blockage, when you look at the ear, it does look a bit wet still. And you have to explain to patients that that's normal. We don't want to try and remove all that staining because it can be uncomfortable. It's not significant. It's just, the analogy I give is, imagine your Sunday roast and you've got your gravy. After you've finished having your lunch, you go into the kitchen. Any leftovers, if there is any, it's not normally the case when I'm having my Sunday roast, but you then remove all the excess waste food, and then you got your plate. The plate's just stained with gravy. And I have to explain that to patients sometimes, because when you show patients back, they always say, oh, there's a little bit of wax there, there's a little bit of wax there, and you have to explain that wax is actually quite healthy for you. And by trying to be too cute and clever and trying to remove every little speck of wax, which is not what the intention is, we just want to alleviate the patient of their symptoms, we can actually cause more trauma. Now, when you become a bit more experienced and a bit more skilled, and it's at no risk to the patient, if there's a bit of wax around the edge, then that's okay. But whenever I'm training my clear wax delegates, at first we always say to them, less is more. Just alleviate them of their symptoms so the patient's happy, and just gain experience and take it from there, really. So you can see half the eardrum, the posterior part, well, it's probably a third of the eardrum, and it's to the back part of the ear. And you can see just how it's got blocked again there, the suction probe, so it just had to come out. And you can see where the narrowing is on the left there. When I entered, you saw the cartilage, and then the ear canal widened. So this is kind of a mid-canal narrowing. And even with patient 2, it's quite similar. The narrowing's more occurred halfway into the ear canal. And still a bit of wax there trapped in the anterior recess. So to the front part of the eardrum, there's a little cave, a little trench, a little recess or a cravat. Sometimes you can get wax trapped in that little widening. And you can see the eardrum, it's fully visible now. So this is a clear wax delegate. I'll say don't worry too much about this. Just in case you graze the ear canal wall. I said myself, I've been doing this for a long time now. I feel really comfortable just hovering across, and the important thing is we don't want to introduce any additional risk. Performing earwax removal has got a range of risks. Whenever we perform a procedure, we get clients to, we explain the procedure. I've got a consent form, and we do get a written consent. Some of the risks involved with earwax removal is obviously bruising, trauma, blistering, bleeding, perforation of the eardrum. These are all very, very low risk, but with anything, if it wasn't low risk, then anyone would be removing wax. So there's always, with any medical or healthcare procedure, there's always risks. It's like with any medication you may take, even the simple paracetamol has its own potential side effects. You can get the caloric effect, so you can get a dizzy when you perform microsuction, but that's just short term. Other additional risks, you can get temporary or permanent or partial or profound hearing loss due to noise exposure, because it is quite noisy. You can get tinnitus sometimes, but again, that's really, really low risk. So in the UK, in primary care, up until recently, the most common mode of earwax removal was irrigation with water, with flushing. So I always explain to patients that this is the same risks attached as irrigation, but far, far less. So this is patient 2. Patient 2 is their left and right ear, and again, they've got a very pronounced narrowing of the ear canal, mid-canal. Slowly but surely just wriggling that out. And similar to the patient one, they've been using a bit of drops. I'd say this patient's ear is actually a bit more narrower. They got a few more hairs in there that's matted. And that glare, that reflection, it's just a reflection of the endoscope, the light off the canal wall, because it is quite narrow. You can see there's some skin there on the right hand side of the ear canal, so that skin attaches itself to the wax plug, so we have to immobilise the wax plug off that skin. You can see just about fit the suction probe in there. So I think it goes to the roof of the ear canal. I think I put some drops in just to loosen this because it was quite stubborn impaction. And sometimes the oil acts as a lubricant. Imagine you have a ring stuck on your finger and you put a bit of soap there just to lubricate it so you can release the ring off your finger. Sometimes with a plug of wax like this, you've got to be careful because when you're suctioning, you can actually, in an attempt to get the suction grip, you can be pushing the wax further in and impacting it. So I managed to wriggle that out. It's got quite a bendy ear as well, so just going to mop up some of the oil. And this is the same patient, and this is their right ear. So I'm stretching open the ear. I've got the endoscope in, and I'm just applying some pressure on the posterior concha canal wall, which means the entrance of the ear canal to the back. That's called the posterior concha canal wall. And we use the endoscope almost like a crowbar. We use it to stretch the ear open. You can see there, straighten the ear as well. See the eardrum. I'm just going to mop up around the entrance. And got a nice healthy eardrum. I hope you enjoyed that.